Hello and welcome to another edition of the Osteopathic Lyceum podcast. I'm going to attempt to do something comparative. So I want to look at suggested contact hours for hands-on osteopathic manipulative uh, or osteopathic manual manipulation is probably the most appropriate term, OMM or OMT, osteopathic manual therapy. I want to do some comparison with respect to contact hours. Now, if you've paid any attention to what I talk about over time, you'll recognize that contact hours is in no way my favored approach to describing educational activities. I'm more concerned about whether or not somebody is observably capable of doing what you say they are capable of doing. But I want to consider the differentiation between an American doctor of osteopathy who will end up, when fully qualified, with an unlimited medical license with specialization because of residency programs, but they will have an unlimited medical license that will be recognized essentially on a national level, but they would have to apply to each given state board to be able to practice within that state because there's varying rules. But once they get through their board exams as a doctor of osteopathy, they then have the right to apply to any of the states. Versus the essentially international hands-on osteopathy profession that tacitly or implicitly points towards the World Health Organization document for benchmarks in training in osteopathy, right? So you've got your type 1 program, your type 2 program, type 1 being 4,000 hours with essentially 1,000 hours of hands-on osteopathic training. People like to say hands-on clinical, right, or supervised clinical, but there's a variety of ways in which that is defined. So realistically, it's 1,000 supervised hands-on training hours, not necessarily 1,000 clinical. I could be making a mistake, and if I am, I apologize for that. Then you have your type 2 program, variable in length depending on what somebody's already been trained to do, and they're looking for essentially 1,000 hours total, not necessarily 1,000 hours hands-on, but 1,000 hours total. May be modified depending on previous experience. There is movement in the direction of asking for 1,000 hands-on contact hours, and fair enough, okay? But generally, you've got this magical number of 1,000 hours of supervised hands-on training, which can take many forms. I need you to remember it can take many forms. It's not necessarily actually moving your hands and working on skills. It is more appropriate to say, yes, moving your hands, working on technical skills under supervision, but also observing upper year students or observing instructors treating and getting a debrief. You could observe medical professional or healthcare professionals of other professions treating and getting debrief. You can have an upper year student watch you treat and give you a debrief. This is a varied thing. So when people talk about supervised clinical hours, there is a minor detail that maybe they don't know that they're not paying proper attention to. It's possible, or they're, giving me some smoke and mirrors. I'm not sure. We compare that magical 1,000 hours, which I don't know where it came from, to OMM training in American colleges of osteopathy, aka programs that will lead you to become a doctor of osteopathy once you've passed all board exams. Now, I'm going to tell you what I'm reading from isn't necessarily an individual school. It is an overview. It's like a Google overview. When you do a Google search, it gives you that AI overview. I'm not a giant fan of these because there are definitely going to be errors contained within, but it gives us a broad understanding and it'll point to the particular websites that it grabbed the information from, okay? I'm saying this out loud because I want you to know that this is not a comprehensive statement. It's a ballpark general range. So I'm going to read this. In the United States, training in osteopathic manipulative medicine, OMM, also known as osteopathic manual manipulative treatment, is a required foundational component of Doctor of Osteopathic Medicine curricula, generally comprising 200 to 500 additional hours of specialized hands-on training. Okay, there's a range. It seems like the minimum is 200 to be acceptable to then go past your COMLEX hands-on If you can do 200 hours and pass your COMLEX, I think it's level 2, the federal government, or really the regulatory bodies in America, will consider you competent enough to perform hands-on manual osteopathy on the general public. 200 to 500 hours. 500 on the top end, 200 on the low end. To continue to read from this overview, medical school curriculum predoctoral. DO students receive over 200 hours of training in the philosophy, techniques, and application of OMM. Some estimates suggest around 100 hours per year in the first 2 years, often involving 2 to 3 hours of weekly lab time, right? So you get probably a lab or 2 every week, and you end up passing your COMLEX. If you pass your COMLEX with the hands-on, which I believe is COMLEX level 2, you're good to go, right? Postdoctoral residency, which is optional. DOs who wish to specialize in this field can complete a 1 to 3 year residency in neuromusculoskeletal medicine, NMM/OMM. That's weird. No, there's some other stuff. Please excuse me. So, generally, 200 to 500 hours. Probably 200. Some will be 500, plus the opportunity for some people to do fellowships after they have gotten through their initial education, right? What I'm going to do is I'm going to switch over to something from the AAO. Oh, no, I'm not going to do that. That is not what I wanted. Please excuse me. It's giving me mild trouble. Okay, so from the American Academy of Osteopathy, if you want to become a fellow or do a fellowship in OMM through the AAO and be recognized, I believe it's FAAO. So you'll see people with the additional credential of FAAO, which is a fellow of the American Academy of Osteopathy. They've done further OMM training. I'm going to read the pathways. Is it the pathways? Where is it? Yeah. So this is on page 2 and 3 of the document from the AAO. So it's the catalog of AAO ONMM residency programs. I'm going to read all of that. This is going to be on page 3, right? 48 months of training. All programs are credited for all options, but may determine at which level they want to accept applicants. Those who complete the ACGME accredited ONMM program will be AOB and MM board eligible. Residents who wish to combine 2 specialties can enter an ACGME combined program for 48 months of training, or complete a 3-year residency in another specialty that incorporates strong OMM components and enter ONMM3 in year 4. Both options result in board eligibility in both specialties within 48 months. So there's a few ways to do it. The 3 years isn't necessarily all OMM, it's just got OMM in it, right? There's varying pathways is essentially what that's saying. Yeah. I'm not going to read that. I'm going to read the final paragraph here. To enter at ONMM 3 level of the program, applicants must complete AOA approved or ACGME accredited residency programs with osteopathic recognition. Residents must also have completed 12 months of rotations that could be applied to the ONMM program. Residents should also show a significant osteopathic component in their training. It is recommended that they complete 300 ONMM outpatient visits and 15 treatments in the areas of pediatric surgery, OBGYN, and 15 inpatient ONMM consults. The ONMM program requirements may be found at the ACGME website. If your training doesn't exactly match the requirements listed, contact the programs you're interested in. The program director has flexibility to work with you and help tailor a program based on the education you have and your training goals. Okay, so 300 outpatient visits split up in a variety of ways. One of the problems with any form of residency program, when you suggest a certain number of visits for particular categories, you don't know what's going to walk in, so you end up having trouble. I will say that what will end up happening is the students will be running around looking for checkboxes. It's like, okay, does this particular visit fall under pediatrics? Does this fall under OBGYN? So they tend to run around just trying to hit checkboxes. And then it's also, well, show that you have strong osteopathic manual medicine manual manipulative medicine, manual osteopathic manual manipulation, whatever, however you want to split those letters up. Show that you have that in your training program. So you've got essentially 200 hours of training, and then you could go forward and do further training, which would include 300 total visits at minimum, likely more, where you're doing hands-on osteopathy in some way, shape, or form. That could be one technique, right? If we are going to compare the levels of legal responsibility at which practitioners will function, doctors of osteopathy in America have unlimited medical licenses, therefore they have high levels of risk and responsibility legally to their patients. Their hands-on training would be considered far lower than what is suggested for hands-on only osteopathic practitioners everywhere other than America. But they will, by regulatory boards, be considered safe. You've got basically 200 versus 1,000 hands-on hours as a general rough guideline to be able to differentiate these things. If you were looking, I think, yeah, if you look, say, on the high end, okay, if you look on the high end of the 500 hours, I'm just going to do a really simple calculation. So you take 500 hours and hypothetically, you divide it by 40-hour weeks, right? So 40-hour weeks, it ends up being 12 and a half weeks, right? 12 and a half weeks of hands-on training at the absolute high end. So let's take that 200 hours and divide that by 40. That's 5 weeks of a standard 8-hour, essentially work or class day. That's 5 possible, like you could classify this as 5 hours on calendar of a standard 5-day, 8-hour work week of learning. And America will allow you to do hands-on methodologies under an unlimited medical license of a doctor of osteopathy, where you would, once you pass all your boards, you could apply to practice legally in each state of the union. If you do more training, 300 visits total, and you're showing other levels of training with no clear prescription that I can see immediately, it doesn't mean that it's not there. Each one of those programs may have a more clear prescription of what they're trying to have you do. When you do the fellowship, often what you're doing is taking part in research, and you're also teaching. So after you have your 200 hours, you turn around and you help teach what you learned in those 200 hours, aka 5 weeks on calendar spread out over 2 years. You turn around and teach that to people who are fresher than you. So if you're going to use hours to describe the hands-on component of osteopathy, if a place that will allow you to do hands-on osteopathy with an unlimited medical license basically needs 200 hours, where did this magic number of 1,000 hours come from? I am not arguing in any direction, aside from the fact that if I'm doing a comparison of less versus more in numbers, I understand how it would be interpreted in one way or the other. I'm trying to describe what's going on, and obviously if I spend time describing that, it can immediately seem like I'm falling one way or another. But what I want to say is that there's a delineation between the two realms or the two pathways to be able to use the term, not necessarily use the term osteopath, but use the term osteopathic manual practitioner, osteopathic manual therapy, osteopathic manual treatment, osteopathic manipulative medicine, osteopathic manual manipulation, whatever term. There's a clear difference in what is being asked of people with hands-on training in different pathways. If that difference is there, the question is simply, why is it there? Where did the 1,000 hours come from? I don't absolutely know. And I'm not trying to diminish the 200 hours. I'm trying to say that there's a difference here if you use contact hours. If regulatory boards in America consider 200 hours a minimum level of safety, as long as you pass your appropriate board exams within the COMLEX series, which I believe, again, is COMLEX level 2. I'm not sure. It may be COMLEX level 3. But you get tested by a board with training at that level, and then you are considered safe to practice on the public. The simple question again, why the difference in contact hours? What explains the difference? I don't know, but I know that there's a difference. And it would be interesting to have some understanding of what that difference is, why it's there, what led to that decision, what led to that number. Because there's a pre-existing regulatory framework that accepts a lower number, but also has that embedded within a much larger training program where people who become doctors of osteopathy carry a much larger freedom to practice, but also as a result of that, much more liability, much more legal responsibility to their patients with respect to the danger profile, because they're allowed to do whatever is contained within medical practice. So it becomes a curiosity, something to consider and something to maybe reconsider. Why 1,000 hours? I understand that it is a common mantra, a common refrain, such that if you say anything other than 1,000 hours, you'll be looked at in a particular way. You'll probably be looked at negatively. But the question again is why? The question, if you say put it on a calendar, right, a 40-hour work week calendar, you have somewhere between 5 and 12 and a half weeks of training for people who are able to pass COMLEX and then do OMM hands-on legally with the public. Then you have this other international standard that says, no, it has to be a minimum of 1,000 supervised. And when people say 1,000 supervised, it seems as though they're saying something like student clinic, and that's not actually what it means. That's not what's delineated there. So again, this conversation becomes curious. Maybe people don't understand what's written in the documents. Maybe they do, and they prefer to frame it a different way. They prefer to look at it a different way. That's fair. It's just a question of what explains this difference. Why? Again, as I said at the start, I'm not a big fan of contact hours. I'm more a fan of being able to observably prove that somebody can do what you say they can do, such that with hands-on therapeutic practice or hands-on manual osteopathy, can they identify motion restrictions? Can they work with those motion restrictions in a way where they compare between approaches and find the one that suits the patient the best with respect to improving range or improving motion characteristic without the patient protecting themselves or without the patient saying ouch? And can they reassess in a way that makes you trust that they can prove that the change actually happened? Not use test A to find it and test B to show that it changed. That is not acceptable. So within those confines, if they can do that, especially if they can consistently, when observed, not have the patient show protective mechanism, then you assume, because of the low danger profile of hands-on osteopathy, that they are likely safe, especially when repeated across time. The more you test, the more likely you are to believe that the people you're observing are able to do what you say they can do. Now, there is a challenge with that. If you test something enough times, it will look reliable. So there is a diminishing return on total number of tests at a certain point. More sampling isn't more proof. It's almost adding noise to the whole deal. So you do have to be careful with over testing things, because sometimes people just learn more and more how to take the test as opposed to how to perform the thing you are testing, right? So there's challenges with that. That said, if you're going to talk about hour count for any reason, I would appreciate some explanation of the discrepancy between 200 hours and 1,000 hours. I'm not saying 1,000 hours is too much. I'm not saying 200 hours is too little. There are obvious value judgments or axiological choices that are made here. There's a value placed on 200, there's a value placed on 1,000. These are different choices by different groups. I think it is valuable to at least be curious and question, or present the question to request an explanation of the discrepancy. What are the value choices and why were they made? If you're going to use hours, explain the difference to somebody, please. Anyways, thank you for listening this far. Hopefully you've learned something, or hopefully you've considered something new, and we will talk again soon.